So thank you, NIC organizing secretary as well as scientific committee for giving us this opportunity to, present this case. What are you giving entity? Okay. So this is a case of go next. 62-year-old gentleman, came with unstable angina, and the only significant lesion he had was total occlusion of RCA with kind of intermediate lesion in ramus. And echo is quite normal, so it's all viable territory, and those are the risk scores. Yeah, next, go. I'll directly get into this is echo, for your understanding that it is normal. Next, go next. Yeah, this is angiogram. You can see a left system is pretty okay, except for a lesion, kind of intermediate lesion in ramus. And you can clearly see, RCA is filling retrograde in this case. Next. Yeah, I can see RCA is filling retrograde, and there is an apical collateral, there is a subtle collateral as well. And if you look at RCA, so it's a total occlusion with an ambiguous cap. You can see there is an ambiguous proximal cap. So earlier they tried antigrade, but they couldn't wire antigradely, so they stopped, and that's where we are. So our analysis of case anatomy is next slide, please. Yeah, I can see clearly the CTO score is definitely a little big because even distal vessel is not visible in angiography. So it's a bit difficult to comment on the length of CTO as well as angulation. But I presume it is a long CTO. There is an ambiguous cap. There is a long CTO. There is an angulation in the CTO. There is no calcium, and it's already failed CTO. So JCTO squares to nearly 3 to 4. So it's going to be a complex case. So the plan is either I was getting cap puncture bar retrograde. So that's my take, and probably I can leave it to chair for discussion. So, and we are planning just angio here. So I first gave deep injection just to understand how the distal vessel is. See, you can see distal vessel is not great angiographically. It is not greatly visible angiographically. So that is when I decided it's even if I do I was graded cap puncture. So it is very difficult for me to understand whether my antigrade wire is reaching, retrograde true lumen. So that is one reason, why I thought it's a primary retrograde case. Though I have an IVUS guided, antigrade cap puncture. So that's what we thought, and we started with primary retrograde. So we have two septals. You can see septal 1, septal 2, and J channel score of septal 2 was kind of 0 to 1. Septal 1 was like 2 to 3, so that's why we took septal 2. This is septal 2. We can see a clear connection and good size. Yes, there are some loops, corkscrew loops, which really doesn't matter in septal. And this is 003 wire. We crossed, patience is the key here. So it took some time, but we crossed within 15 minutes, we crossed septal. Next, please. Yeah. So now we are into RCA. You can see RCA, and I advanced 003 into RV branch to get support for microcatheter. This is Turnpike LP microcatheter, 150 centimeters, which I use retrograde. And from here, now we can see, with a dual injection with Corsair and, antigrade. So we understood it's a short CTO, but the distal vessel was not visible in angiography. And now we started wiring with IVUS over RV branch and the wire escalation retrograde to Gaia 2. Next, yeah, this is Gaia 2, and you can also see IVUS catheter, star beam IVUS catheter in RV branch. The profile is similar to that, like T-cross. And now, can you show IVUS, please? Yeah. So first we located, the proximal cap in IVUS. You can see, play IVUS, please. So the proximal cap comes, you can see at 3 o'clock, something is coming and joining, and then it becomes a big vessel. So next, please. Yeah, you can see this is, cap. So proximal cap, you can also see my retrograde wire within the vessel. Yeah, you can even witness my retrograde wire. So we did, yeah, kind of, I was guided, retrograde proximal cap puncture. See, you can see my retrograde wire is an antegrade movement very much. But what I want to show you is frame by frame. You can see the wire. Wire is at 2 o'clock. If you can see, good frame by frame. You can see the wire is subintimal. So the entry is subintimal, but quickly it became true lumen. You can see, it entered through subintima. So, but that was not my choice. My choice was, I want to come through true lumen. Yeah, once I made a track, I can redirect this wire. But what I decided, I'll see after dilatation, is there any flap which is occluding the side branch? If there is any flap, then I'll try to create a fenestration in the flap, by doing cutting balloon, and I'll decide. So next, what we did, we did externalize wire. Next, yeah. So I took a trap liner. You can see this is a trap liner. And next, yeah, this is retro Gaia. No, but now it is out of trap liner, came back, and then again entered into trap liner. Now you can see my retrograde Gaia 2 is in trap liner, and then we trapped Y and pushed retrograde turnpike LP into antegrade trap liner, followed by externalization. And we externalized and we dilated with the balloon. Next, now I'll show you the iris after balloon dilatation with the 2 mm balloon, and let's see how the distal vessel is. And most important here is how the flap at stem of the RV branches. Do I need to do something to the RV branch? Okay, I was right, and you can clearly see all this vessel is it's a kind of negatively remodeled vessel. I don't see any block in the vessel, but the reason it's not well visible in retrograde injection, probably because of the negative remodeling. So what I'll do is from here understand what exactly where exactly my retrograde wire entry into proximal vessel is. So we can see there is not much of block anywhere in the vessel, but in fact, I dilated with 2 mm balloon here. I prefer to dilate with a longer balloon, longer 2 mm balloon, just to do some touch to this negative. So there is some calcium, but I don't think it really creates a problem. Yeah, you can clearly see, my entry into true lumen is subintimal. So, and it's very clear, if I just stunt, this vessel will just get occluded. So if you can understand, my iris catheter is coming from distal vessel, and if you can see at 3 o'clock, 3 to 4 o'clock, so that is actually, the original true lumen. So my entry into the proximal true lumen, there is a 2 to 3 millimeters of subintimal entry, and you can just play and show segments a little bit proximal frame by frame. Yeah, you can see the wire. So that's a wire, and the wire is in RV branch, and that lumen is connected to true lumen, which is lifted by a false a flap. You can show the flap. The flap is sitting between, the iris lumen versus the RV branch lumen. Yeah, that's a flap. So now I have to, break that flap. So what I can do, I'll do iris from, RV branch and assess the size of the vessel. And then I'll take a cutting balloon and try to create a fenestration. So that's my plan. Probably Chair can, elaborate their views. I came to know that the CTO segment is short only after I injected through the retrograde microcatheter, which is sitting in RCA. Because vessel is completely negatively remodeled, dual injection was not really clear, and it didn't show distal vessel very clearly. So that was the problem. Distal vessel is not clearly visible even in dual injection. In that case, even if I do, IVS guided cap puncture, but it's very difficult for me to understand whether my antegrade wire is in distal true lumen or not, because primarily that vessel is not visible. You can show the dual injection, first dual injection, probably, which makes you see whenever we are doing an antegrade wiring, so clear cap and clear distal vessel. These are the two things which are fundamentally, very important for my antegrade success. In this case, cap is not clear, but I can make it clear by iris, so that's not a point to concern. But the second point, concerning point, is the distal vessel visibility. You can see this is a dual injection, so distal vessel is hardly visible. In such a visibility, it is really difficult angiographically to understand where your wire is. So, and that is a clear point for me to go, primary retrograde in this case. So what's the size of the vessel? RV branch is 2.53. Okay. Nearly 3. No, I want just lumen size, okay? Yeah, I'll come out. So, okay, so just give me a cutting balloon. Okay, so give me a 3 cutting balloon first. So what I'm doing is I'll just take out my trap liner because I want to take probably 2 cutting balloons in. So first I'll do a cutting balloon from RCA and see, how the flap is behaving. Are there any fenestrations in the flap? And then I think, again, I'll do a cutting balloon from RV branch, Dr. Sridhar. Yeah, and then, probably we'll reassess with the imaging. So whether the fenestration is created or not, and based on that, we'll decide, stunting. So katana, cutting balloon. Okay, so I'm using this new cutting balloon from Merrill. It is katana cutting balloon. Yeah, just give me, no, on retrograde wire, please. So first do retrograde wire, that is safer. So since EM size of RCA is like 3.5, and I decided to take a 3 cutting balloon for RCA, and I size my cutting balloon based on the lumen on the other side, not based on EM, because the RV branch is completely normal, so there is no block anywhere. So the lumen size was like 2.6. So probably I'll take a 2.5 cutting balloon, for RV branch. So this is a 3 cutting balloon, so which is going into RCA. Yeah, please dilate. Go to 6. Yeah. Go to 8. Go to 8 atmospheres, please. Yeah. Negative. Yeah, dilate. You can go up to 10, please. Yeah, keep iris ready. You can also show, the flap from RV branch. Yeah, if you can understand or make out, can show, okay? So, yeah, but it looks already there is a little bit of fenestration. Let's see, what happened now. Give me iris. I think I'll do iris from, yeah, probably RV branch, so you can make out fenestration much better. So we treated from RCA, but we are doing iris from RV branch because you can see fenestration better while coming back RV branch. If you look at iris from RV branch, so you can clearly see a flap and fenestration also, the overlap of fenestration onto RV branch also, you can see much better, while coming from RV branch than, while coming from RCA. But of course, we can see from both sides. Flap, whatever flap which is occluding RV branch, whether that got fenestrated or not. Yeah, but whether the fenestration is there or not, I have to see even before I take stunt. If there is no fenestration with balloon, then it is going to close. Okay, so right, I'll just get in a little bit more. Yeah, now we're in RV branch. I'm coming back, pull back, pull back. I don't see a great fenestration. Probably you can again show stop. 2 point for cutting, please. Now I'm doing cutting balloon into IV branch. Only to see fenestration in the flap which is going to close RV branch. I can show you one scene if you guys want. So let's take one scene. So my plan is I will stunt RCA after making sure I'm not going to lose RV branch. That's a plan. No, it's 2.5 in iOS. Yes, see in this RV branch may not compromise also, but what I want to make sure, whatever the flap which is created, that flap, if I can create a fenestration in the flap, so the chances of closure will come down. So that's a basic idea, go to, yeah, right. So I'm just exploring, see, sometimes, if you take 2 cutting balloons and, dilate into 2 branches simultaneously, then, we can create a fenestration in the flap. So it's just that, if I can create a flap, fenestration in that small flap, the chances of losing the side branch is minimized. What's the size? What's 8? Yeah, okay. So now just give me iris. Yes, it's not diffusely diseased. You can show the first iris of RCA. It is a negatively remodeled vessel. So that's the reason I thought of even doing a 2 mm longer balloon. Give me 2 mm long balloon for distal RCA dilatation. So it's a negatively remodeled vessel because there is no block anywhere. You can, Dr. Daya, I think, are you showing RCA? So you can see this is a distal RCA. You can still go down and show. Still go down and show. See, there is no catheter. Yeah, just do an iris. Live iris, please. Long balloon. Please give me a long balloon. It looks there is a fenestration there, right? Just frame by frame. Yeah, there. Can you see at 3 o'clock? At 3 o'clock. No, between 2 to 3 o'clock, 3 to 4 o'clock. So that should be, yeah. So that's a side branch lumen between 3 to 5 o'clock. And between 3 to 4 o'clock, you can see 3 to 4 o'clock. That should be fenestration. Okay. So anyway, I'm just preparing now the distal RCA. Yeah. Yes. Just that. So we are just doing a touch-up work, just to enlarge this negatively remodeled vessel. So I'm not going to extend stunt will be only from block to block. So can you give us the stunt size, please? I think enough. That's anyway, we dilated with 3 cutting balloon here. So I can show you RCA now. Can you give me a little cranial? Give us a little bit NTZ. Now give me IVs, we'll also do IVs from distal RCA, okay? We have to just dilate that area. Just give me the balloon, 2 balloon. So I'll also dilate, the area just proximal to crux, and then I will give you IVs after that. Yeah. Oh, it's okay. So, but here you can see in angio, clearly there is kind of tunneling, So that is not good. So see, there is a tunneling, if you can see, show me the cine place. Show me the cine please. Cine minus. Yes, I'm just dilating this lots here. Are you guys comfortable with this lots here now? Now I'll show you IVs just to prove the point that it is just negatively remodeled vessel. So yeah, just give me IVs from this lots here. And I'll also see the residual luminarias at CTO segment. And if my MLAs are good, probably, I would prefer to just do a deb and come out. That also is my option on the table. No, see, the distal vessel, I have been telling about the distal vessel status in this case. So the distal vessel here is, it's a negative remodeling. It's not a diseased segment. That's a fundamental thing, which I'm talking. You can see this is from crux, I'm doing IVs. So you can see there is no plaque at all. There is no plaque at all. So vessel is pristine. You can see this is a bifurcation. So there is one side branch coming, and see, there is no plaque, which appeared as if, it is diseased. It's because of the negative remodeling. So it's predominantly negative remodeling. Probably you can say there is a little bit of plaque. But I mean, there are ways and means, to differentiate plaque versus negative remodeling, like kind of increased media thickness and all that stuff, which are not super sensitive signs, to really differentiate. But by and large, I'm convinced there is no significant plaque in this vessel, taking from cracks up to the mid arts here. Yeah, I'll show you that part because I think, we came up to the mid RCA, but that's where it got just stuck. So I'm just going back again. So just to show you the, can you check image, please? Right. So this is the CTO lesion. So I'm doing, now this part which I missed in last time. So you can see again. So I mean, I don't see much residual. Probably, Dr. Daya will calculate block areas, but for me it looks, yeah, this is one spot probably, I'll dilate, but if I look at, MLA, when compared to distal lumen, MLA is okay for me. Yeah, flap is also seen, yes. Okay, so Daya, I'll stop here. Can you tell us the lumen areas? So distal reference versus what's the lumen area at the site of proximal cap? Yeah, you can here you can give the distal reference, no problem. I mean, we just dilated with 3 cutting here, right? So yeah, this is a distal reference. Okay, you come to the proximal cap and tell me what is the lumen area. Yeah, 4.6, come proximal. Against distal reference of 3.6, come proximal. See, we have a distal reference of 3.6 at mid RCA beyond the lesion, and we have a reference area of 4.6 at proximal cap. See, I achieved an area which is much bigger than the distal reference at the site of proximal cap. So, and yes, there are dissection flaps, but I'm sure these flaps are not going to create any problem to me. So at least imaging wise, I'm pretty convinced that I can just do a DEB and come out and recheck angiogram after 3 months. You can give me cutting balloon again. I'll just do in that place. So anyway, I decided to do DEB. I'm comfortable. I'll just show you IVs, and then I will move on to DEB. You went up to 10 atmospheres. Okay, right. You can also go up to 12. So what's RBP of this katana balloon? 10, 10, 10, go to 10. I think 12 is RBP. Right. So, right. I'll show you again the IVs of that lesion area. And if there is no exacerbation of dissections, then I'll just move on to DEB and see how his anatomy, These days, we are doing a good number of investment procedures, and we are pretty observing, how the vessels are responding, after investment procedures. I feel more and more comfortable in, leaving dissections. If I have any questions about the support, then I would always prefer, ampulature. So in this case, when you take ampulature, one more problem, especially for IVUS-gated cap punctures, and it becomes very difficult, for IVUS-gated cap punctures in RCA with AL. That's the primary reason why I preferred, taking JR, because when I decided mostly this case is primarily retrograde, JR also provides a comfort of easy externalization than AL. I mean, it's a choice. I do prefer AL in most of the cases, but yes, if there is a case where I think I'm just going retrograde and there is not much of calcium, then it is reasonable even to take JR, because that is a better guide for externalization than AL. It's in my lab, it's a protocol for all CTOs. It should be a long femoral sheath, 45 centimeters femoral sheath. So you need good support, and in this case, I use retrograde through femoral sheath. Antegrade is through radial. So especially when I'm going retrograde, you need good support for microcatheter pushability. Yeah. So what's a lumen area at proximal cap, please? This is proximal cap. So almost 4.5, and you can go a little bit down. So it's nearly 100% lumen area. Just go a little down. Down distal, measured calcium. Yeah, here, what's the area? So, no, I think you can still adjust. And it's almost close to, see, my residual area stenosis at the site of lesion, precisely at the site of proximal cap, which is the hardest in this patient, is 4.4 against 4.6 of, distal reference. Am I correct? Distal reference. Yeah, it's okay. It's 4.6 distal reference, 4.3 to 4.6 is at the proximal cap. So I'm pretty okay, to do a DEB and come out. So probably, I decided to go ahead with the DEB, and I'll do DEB and come out. Give me DEB. Thank you.